Assalamu alaikum wa rahmatullahi wa barakatuh. Dear doctors, today we are going to discuss a very important topic for all anesthesia and critical care physicians. It's about airway management. In this presentation, we are going to highlight some important topics about airway anatomy and how to assess the difficulty of airway, how to handle airway manually, airway adjuncts, and then we'll move to the full details about the difficult airway society guidelines, plan A, B, C, and D. Simply, we need to answer the question, what should I do when I deal with a difficult airway intubation? We need to formulate a very clear and well-structured brain map about that. So let's start this presentation with airway anatomy. As you see, we have here three parts of the pharynx: nasopharynx, oropharynx, and hypopharynx, where you can find the airway inlet, which is our target, guarded by epiglottis, and this space in between the base of the tongue and epiglottis, which is the vallecula where you put your blade during the intubation trial to elevate the tongue upwards, so you can see this beautiful view, epiglottis, two vocal cords, and the view in between. For airway assessment, the most common way to do it is Mallampati score. Very famous and well known for anesthesia doctors. Usually they ask the patient to maximally open his mouth like this, and if he can see all the structures clearly, hard palate, soft palate, uvula, and pillars, so this is going to be easy intubation. This is class 1. If he can't see the pillars and the tip of uvula, this is class 2. If he can see only hard palate and soft palate, this will be class 3. And if he can see only the hard palate, this is class 4. This one is predicted to be a difficult one during the intubation trial. But unfortunately, we don't have the chance in ICU field to do Mallampati score like this because, as you know, the ICU patient is frequently being hypoxic on a face mask, so it's quite impractical to remove the face mask to assess him like Mallampati score. But this is the airway classification when you see it like grade 1. If you can see the whole structure, very beautiful view like this: epiglottis, arytenoid cartilage, vocal cords, and the view in between. This is grade 1, very easy view. If you can see the lower half of the view, this is grade 2. If you don't see the view, you can only see the epiglottis. This is going to be grade 3. And finally, and the nightmare, you can't see anything. Even you can't see the epiglottis. No epiglottis, no view. This is grade 4. So there are some very well known for most of us basic manual techniques to handle the airway. Most famously, head tilt, chin lift. As you see, the tongue is elevated away from the posterior pharyngeal wall to restore the patency of airway again. Here it was obstructed completely by loss of the tongue tone, but we need to make sure that there is no concern about possible cervical spine injury. If you have that concern, you have to try jaw thrust only, just to pushing the mandible upward and opening the mouth in this way, but don't manipulate the cervical spine at all. We can combine both of them and do triple airway maneuver, which is simply jaw thrust with simple head tilt. And after that, you might consider airway adjuncts to help you to get more control, either oropharyngeal airway or nasopharyngeal airway. So these are the types of airway adjuncts: oropharyngeal airways, nice colors, different sizes, and the nasopharyngeal airways with different sizes as well. Most important thing to be mentioned here is about the sizing. We need to choose the correct size for the patient very accurately, because if the device is too long or too short for the patient, it wouldn't do its job effectively. So for oropharyngeal airway, we size it from the midpoint of incisors till the mandible angle of mandible here. This is the correct way to size it. For the nasopharyngeal airway, it's from the tip to the tip of the nose till the tip of air loop. This will be the correct size for the nasopharyngeal airway. We need to remember that the oropharyngeal airway should be used only and only in the unconscious patient. You can't use it in conscious or semi-conscious patients for one reason. It stimulates gag reflex, and it could induce possible vomiting with subsequent aspiration, and you will lose the control over the airway. In this situation, if the patient is conscious or semi-conscious and has possible gag reflex, you need to use the nasopharyngeal airway. But we need to make sure that he has no fracture base of the skull to use it. I think this device is my favorite, and it's very easy to be inserted. Now, after this simple introduction, let's go to the serious part of the presentation. This is the Difficult Airway Society UK Guidelines 2015. This is the full overview about the whole process of intubation scenario. There are 4 steps: Plan A, Plan B, Plan C, Plan D. Plan A is tracheal intubation, laryngoscopy, and tracheal intubation. And we will explain in details how can we do it correctly and safely. If we succeed to intubate the patient, we need to confirm the tube position by capnography. Capnography should be the gold standard to confirm the tracheal tube position. If we fail the intubation, this is the question we need to answer. What's next? What should I do? Plan B, okay, you don't have a tube, so at least maintain oxygenation. The patient is going to die from hypoxia, so try to maintain oxygenation. Plan B, to maintain oxygenation by insertion of SAD, supraglottic airway device, laryngeal mask. So try to insert that one, iGel. If you succeed, you need to stop and think, what's next? There are many options here. Just to keep it in place and wake the patient up is fine, or to proceed through the laryngeal mask and intubate the trachea, and we'll discuss in details how can we do that, or to do tracheostomy and the cricothyroidotomy. There are many options here. I would say consult a senior anesthesiologist and take a decision with him. Stop and think. Next step, if we fail to insert the laryngeal mask? So try to keep oxygenation by another method. Face mask ventilation, the classic face mask ventilation, 2-person technique. One is holding the mask, the other one is giving the ventilations. So if this succeeds to improve the oxygenation and bringing the saturation up, it's okay. Just keep giving face mask ventilations and wake the patient up. If we failed to control the oxygenation, now the horrible scenario, can't intubate, can't oxygenate. Kiko. We can't do both of them. We can't intubate and can't oxygenate scenario. The only solution here is Plan D, emergency front of neck access, cricothyroidotomy. And we are going to discuss each one in details. So again, our plans: Plan A, laryngoscopy, tracheal intubation. If I failed, move to Plan B. We need to maintain oxygenation through insertion of laryngeal mask. If I failed, we need to maintain oxygenation by another way, which is face mask ventilation. If we fail, the last step is going to be emergency front of neck access, FONA, front of neck access. This is the full overview, Difficult Airway Society guidelines. In very well organized ICUs, you can find the difficult airway trolley. Very nice trolley with 4 drawers, and each drawer is responsible for, or we can say matched very well with the difficult airway guideline. The first drawer for equipment of Plan A, and the second one you can find equipment of Plan B, the iGel. The third drawer you can find the equipment for Plan C, and the final drawer for the Plan D equipment, front of neck access equipment, scalpel, BG, and tube. Very nice, very well organized to help you to take quick decisions during can't intubate, can't oxygenate scenario. So in the usual practice, everyday practice, we usually start the intubation process by this paper. This paper should be available in all ICUs because it helps the physician to prepare everything before the intubation trial. This is the key of successful intubation trial. We need to be prepared. To prepare the patient, to prepare the equipment, to prepare the team, and to prepare for difficulty. This is very important. So you need to hold the paper and tick all these boxes to make sure that everything is done and we are not missing anything. For the patient, for example, you need to secure a good IV access, optimize his position. You need to assess his airway. We need to pre-oxygenate him for 3 minutes at least. We need to optimize the patient's state from the hemodynamic point of view. This is very important. Many times we give propofol and we surprised with hypotension. That's because the patient's hemodynamic state was not good before the intubation trial. So try to give some fluids, try to prepare vasopressors with you. Something like metronidazole, just in case. If blood pressure goes down, you need to interfere immediately by giving some metronidazole and control the situation before development of hypotension and arrest. We need to prepare the equipment, all equipments, tubes, laryngoscopies, laryngoscopes, video laryngoscopes, bougie, stylet, suction, and test everything. Make sure about the cuffs, inflate and deflate, even the jelly. Prepare everything. Prepare the medications, the anesthesia, the muscle relaxant, everything. We need to prepare the team. This is very important. We need someone to be responsible for giving medications. Someone would be responsible for cricoid compression. Someone is going to be responsible for the monitor. Someone would be the leader. Someone should be the intubator, and so on. To allocate the roles. Speak with your team. This is an example for that. If we have 6-member intubation team, first intubator, this is the patient, this is the monitor, this is the airway equipment. So we have first intubator, second intubator, the guy who is responsible for drugs and the monitor, the guy who is responsible for cricoid compression, the runner to get help, and the team leader. And here, if we have 5 person, and here if we have 4 person. So the allocation of rules is the key for the team working, which is very essential for successful intubation trial. And the last thing, to prepare for difficulty, simply to speak with your team and verbalize the plans like Plan A, Plan B, Plan C, Plan D. We are going to start with Plan A. If we failed, we'll do Plan B, then C, then D. Verbalize it very clearly to them. Explain it to them. Involve them in the event. Again, time working is very important, and a very important key for successful intubation trial.